Hi guys, good evening. Good evening. Hope everybody is able to see me, able to hear me. Uh, Abu Hashim, sir, taken detail will be helpful for upcoming NEET SS exam also. Abu, we will continue to do so. We'll try to take the entire topic in the wholesome. Yeah, for a resident level, I need to put in a little bit of more effort because most of the students are listening here as an undergraduate. We'll have to stick to Bailey. I would consider, for a NEET SS, yes, that's something that I'm really interested in. We'll try to add a bit to it where we'll say additional NEET SS series and then we'll continue on the same. Hi, good evening, Anish. Good evening, Mansoor. Right. So I think everybody is plugged in. Let's begin from where we have left off. Again, today is going to be a quite interesting one. So yesterday we spoke about the chemotherapy, we spoke about the regimen, we spoke about how do you administer it and blah, blah, blah. We spoke about the response assessment. So we'll talk about the hormonal therapy, right? Today is about hormonal therapies as well as we'll talk about the breast surgeries as well. Hi, Krishna. Good evening. Hi, Shubham. Good evening. Good evening. Right. So today we'll be talking about, one second guys. Okay, so today we'll be talking majorly about the breast surgeries. At the same time, we'll be talking about the rest of the treatment protocol. So about the hormonal therapy. As we have dealt yesterday only, the criteria to give the hormonal treatment or the hormonal therapy, the most important criteria that has to be satisfied is the ERPR status. That is the estrogen receptor and the progesterone receptor. If it is positive, we will go ahead with hormonal therapy. Now, the hormonal therapy that we can give, I can divide them based upon the age of presentation, whether the patient is pre-menopausal or post-menopausal female. Whether the patient is a pre-menopausal female or whether the patient is a post-menopausal female. Or a post-menopausal female, right? Now, when we talk about a pre-menopausal female, for these patients, I would like to go ahead with selective estrogen receptor modulators. That is going to be SERM. It is your selective estrogen. You go ahead with selective estrogen receptor modulator. Now, the examples of selective estrogen receptor modulators are like tamoxifen, and a better drug is going to be roloxifene. Now, tamoxifen has another problem is, if a patient is using tamoxifen, it increases the risk for endometrial cancer. It increases the risk for endometrial cancer. Now, whatever your selective estrogen receptor modulator that you're going to prescribe, for how many years are we going to give it? Remember, this has to be given for next 10 years, right? So this is recommended for 10 years. Now, for a postmenopausal female, I would go with a better drug, and by saying that, I would go ahead with aromatase inhibitors. I would go ahead with aromatase inhibitors. Now, this aromatase inhibitors can be classified into two categories. One is a steroidal, another one is non-steroidal inhibitors. We have the steroidal aromatase inhibitors and the non-steroidal aromatase inhibitors. So when I say steroidal aromatase inhibitors, the best example of steroidal aromatase inhibitors are exmistan. It's a exmistan. Non-steroidal is going to be letrozole as well as anastrozole. So your letrozole and anastrozole is non-steroidal aromatase inhibitors. Exmistan is a steroidal aromatase inhibitors. Now, when it comes down to exmistan or the per se as this your aromatase inhibitors, if you give aromatase inhibitors in premenopausal female, it will result in hot flushes, right? So the side effect of aromatase inhibitors in premenopausal female, it will result in hot flushes, right? Another side effect is of the aromatase inhibitors, it results in decrease of bone mineral density. So aromatase inhibitors result in osteoporosis. And this osteoporosis will result in pathological bone fractures, right? So this is with respect to that of the hormonal therapy, right? So hormonal therapy, if you follow this, this is the whole context that you have to look across here. Now, along with hormonal therapy, the last option that you had is about the post-operative radiotherapy. So when you talk about the radiotherapy that can be given into the breast, we can categorize them into two contexts. One is your whole breast irradiation. We call it as the WBI. WBI stands for whole breast irradiation. Another one is your accelerated partial breast irradiation, that is ABPI. The accelerated partial breast irradiation. Now, when you talk about ABPI, it is basically that you do it for your breast conservative surgeries. In rest everywhere, you do a whole breast irradiation. So if you look at the comparison between both of them, remember for a whole breast irradiation, it will be a 25 days component, or the radiation is given for 25 days. Every single day you have to call the patient. This is only given for 5 days. This we give as 1 sitting per day. ABPI is given as 2 sittings per day. The total radiation exposure that a patient is going to get, the total radiation exposure that the patient will receive here is going to be 50 to 55 gray units. Whereas here the total radiation exposure is going to be 20 to 25. The total radiation exposure that you will give here is going to be 20 to 25 gray units. It's going to be 20 to 25 gray units, right? Now, what are the sites that you will give? Now, ABPI is very simple. It is only given to the tumor cavity. Whichever side you have removed the tumor, only to that, it is only given to the tumor cavity. So, radiation is only given to the tumor cavity. This is what we call it as ABPI. Whereas here, when you talk about the radiation exposure, if this is the representation, right? So what are the sites that we are going to cover for radiation? Just give me a second, guys. I'm getting a constant call. Could have been from a hospital. Just hold on first. Right, guys. So yeah. So this is our axilla, which is here. This is the axillary groove that is present here. And let's say this is the area where you have removed the breast, right? Post MRM, we're talking about radiation, right? So what are the sites that I'm going to give the radiotherapy to? I am going to give the radiation to the entire chest wall. So this is the chest wall that I'm going to give. So the entire chest wall is going to get the radiotherapy. I will not give any radiotherapy in the axilla. I will give in the infraclavicular as well as in the supraclavicular space. I will also involve the internal mammary group of lymph nodes, right? So I've given the radiation to the chest wall. Sorry, I've given the, so if you look at the entire sites, what are the sites? I can just list it down for you. I've given the radiation to the chest wall. I've given it to the infraclavicular space and the supraclavicular fossa. And to the supraclavicular fossa, we'll also give it to the internal mammary group of lymph nodes. Also giving it to the internal mammary group of lymph nodes, right? These are the sites where you're going to give radiotherapy, and this is the whole objective here. If you remember, no, when we spoke about the anatomy, in which we talk about the various levels of lymph nodes in the breast, and I told you that in level 3 group of lymph nodes, we are not going to involve the internal mammary group of lymph nodes. The reason being quite simple, because internal mammary nodes will not be dissected during the surgery. We do a targeted radiotherapy in the post-operative period that will take care of the issue. Okay? So this is about the post-operative radiotherapy, right? Now, we have come across the whole component. We started with stage-wise management, in that we had 3 different contexts. We had the surgery option, we had the chemo and the radiotherapy, and every single thing has been presented in front of you. Now, there is a small, I would say, an additional component that is put across here. This is going to be the IHC, that is the immunohistochemistry part of it. It's about the molecular status, and then we'll try to understand that how well we can analyze and then give the treatment accordingly. So based upon the IHC categorization, that is your immunohistochemistry. Now, IHC stands for immunohistochemistry. I stands for immunohistochemistry, right? So in this, we will be analyzing number 1, ER status. ER stands for estrogen receptor. We'll be analyzing PR. PR stands for progesterone receptor. So we have the ER and the PR receptor, that is estrogen progesterone receptor. I hope everybody knows that ER, PR, the estrogen or the progesterone receptors, no, they are nuclear receptors, right? So they're basically, we call it as the steroid receptors. They are usually the steroid receptors, and when you use the stain, here the nucleus is going to stain brown. Here the nucleus stains brown in color, right? Then you have another component, that is your HER2 neogene. Now the HER2 neo is basically, when I call it, it's a membrane receptor. It is a membrane receptor. This is your membrane receptor. Now here the cell membrane is going to stain. Here the cell membrane stains brown in color. Here the cell membrane stains brown in color, right? Normally, no, when you talk about the score, how do you analyze this about the receptor staining and all that? So we have a scoring component here. In order to know how dark the color is and how more it is picked up, for the receptor status, that is your estrogen progesterone receptor, we use a score called as the Aldred score. We call it as the Aldred scoring, and this Aldred score is scored between 0 to 8. 0 means no stain, 8 means the most darker color in the context, right? Now, in the same context, when you are looking for the HER2 neogene, now the results of HER2 neogene stain. Now, when you look for the HER2 neogenes, again in the base of Aldred score only. So when you look at the scores on the HER2 neogene, you can have a score of 0 or 1, right? You can have a score of 2 and a score of 3, right? Now, if there is a score of 0 to 1, that means it is negative. HER2 neogen receptor is negative. Score of 2 indicates equivocal, and a score of more than or equal to 3. A score of more than or equal to 3 indicates positive. That means it is positive for HER2 neogen receptor. Now, usually, whenever you get an equivocal, this is where you have to work, because it is neither negative nor positive. So what are you going to do in order to analyze what you have in picture, right? On an equivocal status, I will go ahead with fluorescence in situ hybridization, that is a fish. And then we will see on fish whether it gets amplified, or it remains non-amplified. If it gets amplified on fish, is positive, non-amplified indicates negative, right? So this is how you're going to look for your molecular status, right? So this is about your IHC, that is a immunohistochemistry. Now the same thing if I put across here. Okay, so to understand or make it more easier, I will use a small criteria which is called as the luminal criteria. Now this luminal criteria is going to tell us about the tumor behavior. It will tell you about the receptor status. It allows me to choose my treatment protocol, as simple as that. So what are the parameters that you're looking at? Here we are looking at estrogen receptor, progesterone receptor, HER2 neogene status. Then you have Ki67, which is a proliferative index, and a cytokeratin 5 and 6. Again, the tumor nature that is going to be determined by this. Now you have different components here. The first one is going to be something called as the luminal A criteria. Now in a luminal A, it is the ideal presentation where ER/PR is positive, HER2 neogene receptor is negative, because HER2 neogene determines the aggressive potential. Now Ki67 is going to be low, that means the proliferative index is low, that indicates it is not an aggressive tumor, and the cytokeratin stain is negative, again indicating a non-component, that means it indicating it's a non-aggressive tumor. Then you have something called as luminal B. Now luminal B, when you look at this, in a luminal B, you can have estrogen receptor positive, progesterone receptor positive, HER2 neogene is also positive. And when it comes down to your Ki67 index, the Ki67 here can be low or it could be high. It could be both low or high. The cytokeratin stain remains negative. It remains negative. It is luminal B. Another variation that we recently found on a luminal B criteria. It can be same as luminal A only. That means ER is positive, PR is positive, HER2 neogene is negative. But here it is going to remain high. That is Ki67 is high and cytokeratin negative. This will also be considered as luminal B criteria. All those people who are preparing for your competitive exams, especially for your NEET or INICET, this is our watch out point, right? Do not forget to pin this out, because this determines that do you understand the luminal B criteria or not, right? Then you have the basal cell type. Now in a basal cell, you will see the ER is negative, the PR is negative, the HER2 neogene is also negative, right? Here the Ki67 can be both low as well as high, and here cytokeratin remains negative. Classically, when you see the luminal B criteria, you see all three parameters, ER, PR and HER2 neogene is positive. No, because all three of them are positive, luminal B is also referred to as the triple positive breast cancer. Whereas in basal cell, you can see all three of them are negative. All three of them are negative. So this is called as triple negative. This is referred to as the triple negative breast cancer. This is your triple negative breast cancer, right? Now, another one that you have is an unclassified, or also called as the Cowden low variety. You can call it as the unclassified, or also referred to as the Cowden's low variety. A Cowden low variety. Now in this, this is going to be negative. This is going to be negative. This ER, I mean all three of them remains negative. Ki69 index can be low. It could be high. The cytokeratin also remains low. That the cytokeratin value also remains, or the cytokeratin stain also remains no, right? Now in the basal cell type, when you talk about specifically, there is something called as the HER2 neotype also. Now in a basal cell, no, see, In a basal cell variety where you have triple negative, actually talking, the cytokeratin stain is positive, not negative. Just make a small correction. Cytokeratin is negative because there's something called as HER2 neotype. We call it as the HER2 neo exclusive type. The ERPR is negative. HER2 neo gene is going to be positive, also called as HER2 enriched. Again, here Ki67 can be both low as well as high. Cytokeratin stain remains negative. The cytokeratin stain remains negative, right? This is quite important for us to determine. Okay? Clear? So this criteria, I know it looks a little bit extensive when you look at this. If you have ERPR positive, HER2 neo gene negative, low Ki67 index, and cytokeratin stain negative, it is luminal A. As you can see, all good things are here. So remember, this is the one which is associated with the best prognosis. If your patient comes with this, this is your best prognosis. On the other hand, if your patient comes to you with this, all three are negative, right? So there's no drug that you can give. On the other hand, the Ki69 index can be high also. So this is the one which is associated with the worst prognosis. So the best prognosis and the usual variety that you will see, the best prognosis and the usual variety that you would see. Did I lose you guys? Okay. Is going to be your luminal A criteria. The worst one is going to be your basal cell variety. The worst one is going to be your basal cell variety. Now, based on this, whenever you have HER2 neogene positive, a patient who presents to you with the HER2 neo positive status, then here I would give trastuzumab. It's a monoclonal antibody, also commonly referred to as Herceptin, and this is what is prescribed for HER2 neogene positive status. For the HER2 neogene positive status. So this is how we are going to address based upon the luminal criteria, right? So this allows me to determine the prognosis as well. Clear? Great. So receptor status positive is good, receptor status negative is bad. It indicates more aggressive tumor, and luminal criteria is what it determines more. Remember, Ki67, those who do not understand, it indicates the proliferative index. So whenever you have a high Ki67, that always indicates that it is going to be an aggressive nature. It is going to be a poor prognostic factor as well. Okay? So this is all in all that you should know with respect to that of the luminal criteria. I hope everybody is clear with this. A quick feedback, because luminal criteria is slightly extensive criteria, but I do want you to know, because a lot of questions, and especially when you're preparing for your competitive exams, it's one of the most important topics. Yes, this is there in our Bailey, same table, same thing. I have just put it in my own language so that it allows you to understand it better. So for any questions, guys, quick feedback. Quick feedback. Okay. If there are no questions, now let's dig into the topic of the day, that is going to be our breast surgeries. So we'll talk about the various breast surgery. Now there will be various terms that are used with respect to breast surgery, but first of all, always standard. What is the position in which you're going to put the patient for breast surgeries? What are the incisions that you're going to lay across, right? So the position for all breast surgeries is going to be supine position. The incision varies based upon the purpose, right? So what are the different incisions that we have? Just for the sake of understanding, you take this as the representation of the breast. This is the axillary tail of Spence, right? So see, what are the different incisions that we can talk about it? Right. Now, when you talk about the standard incisions in the breast, I'll just quickly tell you the various names of it, and then we'll proceed for this. Now, you take this as the representation of the nipple and the areolar complex. So this is the nipple area complex. I've drawn the axillary tail of Spence as well, right? Now, the first incision is going to be a cosmetic incision, which you're going to put around the areola, right? So just around the where the skin and the areola are meeting, now I'm going to put my incision there so that the scar gets hidden in there, and this incision is what we call it as the circumareolar incision. This is what we call it as the circumareolar incision, and this circumareolar incision is also referred to as the Webster incision. This is also referred to as the Webster incision. The circumareolar incision is what we call it as the Webster incision. Another one is if you want to excise a bigger lesion, but again you don't want a scar, this time you go from the under surface of the breast, and this under surface of the breast is what we call it as the inframammary incision. This is what we call it as the inframammary incision, and this inframammary incision is what we call it as the Galliaro's incision. This is what we call it as the Galliaro's incision. This is your Galliaro's incision. So you have the circumareolar incision, you have the inframammary incision, and then comes for the malignant disorders where you extend the incision elliptically from both the ends like this. This is one end of the incision. Another one, you can point it towards the axillary tail of Spence and make the incision like this. So one, we have the horizontally elliptical. One you have horizontally elliptical. Another one is obliquely elliptical. We have horizontally elliptical, and then you have obliquely elliptical. Horizontally elliptical is what we call it as the Stewart incision, and obliquely elliptical is what we call it as Orr incision. It is the Orr incision. Now the carry message that we need to know that the first two that we spoke about, that is the Webster and the Galliaro's incision, they are used for benign disorders. These are used for benign disorders. And the Stewart and Orr, this is used for breast cancer. This is going to be used for breast cancer, right? So these are the various incisions that we are going to talk about it. Now, what are the different surgeries that you have? Now, there's a list of surgeries that we'll be talking about. We'll try to understand, analyze every single thing and make sure that we have a sound understanding for this. Now, see, due to YouTube restriction, I cannot show you the original surgical videos because last time when we tried it, the minute we start playing it, the YouTube blacklists us, so just the videos go off. So I'll try to keep it on a pictorial form so that you all understand it and then you can resonate with me at the same time, right? So what are the different incisions that we have, or different surgeries that you have? I'll start with the very basic one. Number one is something called as the wide local excision. So when you go with a wide local excision in the breast, so what do you mean by this wide local excision is, if you take this as the representation of the breast, this is the axillary tail of Spence. Let's say this happens to be the nipple and the areolar complex, and let's say this is the lesion that is present here, right? So when we say a wide local excision, in the wide local excision, I am going to remove the tumor, but at the same time I'll take some amount of margin along with the tumor. Now when I excise this, right? So when I excise this and I'll just take this here, you will say I would have removed the lesion. I would have removed the lesion. Along with the lesion, some amount of normal breast tissue. Some amount of normal breast tissue will also be removed, and this is what we call it as wide local excision. Now the interesting question is, when you remove it, this is what we call it as the margin. This is what we call it as the margin, and the margin should be uniform all across the lesion. Now remember, the margin that you have to take for a wide local excision, it is going to be 1 centimeters or 10 millimeters. A margin that you're going to take is going to be either a 1 centimeter or a 10 millimeter lesion, or a 10 millimeter lesion, right? Now, what are the other synonymous terms? Now to confuse you, they would use other terms for wide local excision. Now, wide local excision is also commonly referred to as lumpectomy. You're removing the lump. So this is what we call it as lumpectomy. Now, if I add wide local excision, if I add wide local excision, if I add wide local excision with radiotherapy, if I add wide local excision with radiotherapy, then this is what we call it as breast conservative surgery. So this together will now be called as BCS, and BCS is nothing but breast conservative surgery. BCS is what we call it as a breast conservative surgery, right? Now, we all understand that when you do a wide local excision, or when you're talking about doing a lumpectomy, or you're talking about a breast conservative surgery, you have created a defect in the breast tissue, right? Now, how do you overcome the defect in the breast tissue is what we call it as an oncoplasty. Now, I'll just continue here only. That means when you have operated on this breast, after you have operated on this breast, now I see, once you have operated on this breast, now you are able to see that there is some amount of defect that is created in the breast, right? So this is the defect that I have after removing the lump from here. This is the defect that we are able to create. Now, once this defect is there, how do you replace, or how do you overcome this defect is what we are going to look across it. Now, this you can be done with two components, and that is going to be oncoplasty. Now, all that I have to do is I have to measure that this defect that we have created. So I'm just going to call this as the defect that is created. Now, this defect in the breast that is created has to be rectified, because the whole objective of doing a lumpectomy or a wide local excision or a breast conservative surgery is to give a cosmetically good looking breast. Now, all that depends is this defect that you have, does it occupy less than 20% of the breast volume? So is it less than 20% of the breast volume, or is it more than that of the 20% of the breast volume? So I will look at the loss. I look at how much tissue has been lost. Is it less than 20% of the breast volume, or more than 20% of the breast volume? If it is less than 20% of the breast volume, here we will do type 1 or level 1 oncoplasty. Here we will do a level 1 oncoplasty. Whereas if it is more than 20%, then we would do level 2 oncoplasty. And then you do a level 2 oncoplasty. What do you mean by this? Level 1 oncoplasty is volume displacement. This is what we call it as volume displacement. And level 2 oncoplasty is what we call it as volume replacement. So level 1 is volume displacement, and level 2 is going to be your volume replacement, right? So this is with respect to your reconstructive status. Now, what is this displacement and what is this replacement? So what is this volume displacement, volume replacement? We'll try to understand. So the level 1 that we're talking about, level 1 is volume displacement, and level 2 is what you have is volume replacement. So you have the volume displacement and the volume replacement. Let's try to understand this, right? So this was the breast that is present here, or else just for the sake of understanding, this is the neck, this is the shoulder line, right? Suprasternal notch, this is the sternum, this happens to be the axillary groove, this happens to be the clavicle, which is here. And let's say this is the breast that we are concerned about, right? And this is the nipple areolar complex, right? So we need to understand what is a volume displacement, what is a volume replacement. Okay. Now, in a volume displacement, let's say this is the amount of volume lost. This is the amount of volume lost. So after excising, this was the defect, right? So what we are going to do is, the first thing, I'm going to isolate the areolar and the nipple complex. So we'll give an incision just separating the areola from the underlying skin and lift it. Now what I'll do is, I will just extend the incision here, and from whatever the breast tissue that is present here. So this is the breast tissue that we have. So this is all the breast tissue that we have. All the breast tissue is here. Okay, I'm just highlighting in green. So this is the breast tissue that is available. Right? Now this defect has to be covered. So what I'll do is, I will slowly pull from under the skin, and I will pull the breast tissue from either end, and I will meet them in center. So I've lifted the skin and I'm pulling the breast tissue together, and once I pull the breast tissue together, I am able to achieve the breast tissue to come here. Now once I have the breast tissue here, so just to signify that we have taken the breast tissue, this is where the breast tissue would have reached, and once the breast tissue is reached, we are going to suture these ends. Now you can see the volume is being displaced. You're not replaced it. It's a displacement, and you're covered it. This is what we call it as type 1 oncoplasty, where the reconstruction is done. So the whole objective is to mobilize the breast from the either end to reach this defect. The defect that was created, this defect was filled by mobilizing the breast from around. By mobilizing the breast from around, you are able to regain this reconstruction. So once you have mobilized it, you are now able to regain this entire area, and this regaining of the entire area is what we call it as volume displacement surgery. On the other hand, when we do a volume replacement surgery, let's say the defect is quite big, which is like this, right? Let's say this is the defect that is present, more than 20%. Now what I'll do, obviously I cannot replace it directly. So what I'm going to do is, I'm going to bring a tissue from the back, usually your latissimus dorsi muscle flap, and I'll put the muscle flap here, right? It is a myocutaneous flap that you will take, and then you will fix it here. And once you have it, we're just going to suture the muscle flap here. So when you take a flap and then you pull it and fix it here, this is what we call it as volume replacement. So in the volume replacement, you're taking the breast, you're taking a muscle or a flap to reconstruct that area of defect, and that is what we call it as the volume replacement. So now you know the volume displacement and the volume replacement. Latissimus dorsi, bring it forward, attach it. This is going to be volume replacement. Just allow the dissection from the surrounding areas to fill up the defect. This is what we call it as volume displacement. So volume displacement, volume replacement, displacement, replacement, displacement, replacement. Do not forget it. Displacement is level 1, replacement is level 2. Okay? Higher level is going to be your level 2. Do not forget about it. Okay? So the first surgery that we spoke about is a wide local excision lumpectomy, as well as your breast conservative surgery. We added our oncoplasties here only. Now the second surgery that you have, is what we call it as simple mastectomy. So in the simple mastectomy, you remove the entire breast tissue. So the target here, it is to remove entire breast tissue. So when you talk about the simple mastectomy, so there are two variants that you have. One is what we call it as the nipple and areolar sparing mastectomy, and nipple and area including mastectomy. So there are two different types of simple mastectomy. So one where you have the nipple areola sparing mastectomy, and one is non-sparing. That is non-sparing nipple areolar mastectomy. This is what is a classical simple mastectomy is. So what are you going to remove it? Now, in the context of this, whenever you're looking at the whole concept, you're looking at what are you going to do with the nipple, what are you going to do with the areola of the breast, what are you going to do with the glandular component of the breast, and what are you going to do with the stroma of the breast, which we have discussed in detail in our anatomy lecture. So when you talk about a nipple sparing mastectomy, I am going to spare. So that means tick means to leave it back, and glandular is to, cross means remove it. In a classical mastectomy, we are going to remove all of them, right? So the difference between a nipple sparing and a non-nipple sparing mastectomy is obviously it's quite simple, that in nipple sparing, you'll remove the nipple areola complex to be spared and reattach it back. Non-nipple sparing, you will remove it completely. You're going to remove it completely, right? Now, in this context only, there's another term which is introduced, which is what we call it as quadrantectomy. So the difference between, when you talk about your wide local excision quadrant, wide local excision is fixed margin of 1 centimeter. In quadrantectomy, I'm not going to follow this. In the quadrantectomy, if you take this as the representation of the breast, let's say this is the representation of the nipple and areolar complex, right? And we all know the breast is divided into 4 quadrants on the basis of the 2 lines passing perpendicular to each other crossing the nipple. And if I go ahead and remove one particular quadrant completely, if I excise a quadrant completely, this is what we call it as quadrantectomy, right? Removal of one quadrant completely. Removal of one quadrant completely is what we call it as quadrantectomy. This is what we call it as quadrantectomy. Okay? So, okay, I know my maths is not that great. That is why I took medicine. 2 के बाद 3 आता है तो भूल गए. Okay? So the third surgery that we spoke about is going to be quadrantectomy. Right? Now, once you have understood these two surgeries, so wide local excision is done, simple mastectomy is done, quadrantectomy is done. Next, talk about the fourth surgery, that is going to be radical mastectomy. Now, when you talk about the radical mastectomy is also called as the Halsted's mastectomy. It is what we called as the Halsted's mastectomy. So, in the Halsted mastectomy, what are we going to remove, right? So again, if you take the representation, this is the neck, this happens to be the shoulder line, this happens to be the axilla, and it is here. So you have the suprasternal notch, this happens to be the sternum, Ziphy sternum, this happens to be the clavicle, this is the axillary groove, and then you have the axilla which is present here, right? We all know that two sets of muscle which is going to be present. One, you have the pectoralis major muscle, another one is pectoralis minor muscle. So let's say this happens to be your pectoralis major muscle which is present here, and then you say another one is going to be the pectoralis minor muscle. So you have two contextual muscles which are present. So one is going to be the pectoralis major, another one is a pectoralis minor. The green one is your pectoralis minor, coracoid process inserting into third, fourth and fifth rib, whereas the yellow one is your pectoralis major, that is going to be from the medial two-thirds of the clavicle, all 8 ribs inserting onto the bicipital groove of the humerus, right? Then you see the various sets of lymph nodes are present. This is level 1. I can say the level 1 group of lymph nodes, this is a level 2 group of lymph nodes, and this is your level 3 group of lymph nodes. In a radical mastectomy, number one, I'm going to remove the entire breast, right? So what are we going to lose it? Remember, I will do simple mastectomy here, which we have already learned. What are we going to do? Now, along with simple mastectomy, I'm going to remove 2 muscles. What are these 2 muscles? One is your pectoralis major muscle. Another one is your pectoralis minor muscle. So both these muscles are going to go. So pectoralis major muscle is removed, and the pectoralis minor muscle is also removed. Now, along with that, what else are you going to remove? You're going to remove lymph node level 1, level 2, level 3. All 3 goes. So level 1 group of lymph node, level 2 group of lymph node, and level 3 group of lymph nodes are removed. So in a radical mastectomy, you do simple mastectomy, pectoralis major muscle, minor muscle, as well as level 1, level 2, level 3 group of lymph nodes. All these lymph nodes are removed. Then we call it as a radical mastectomy. Holsters, again, it causes a lot of morbidity to the patient. Hence, radical mastectomies are no longer performed. So the workhorse that we have in the breast surgery as of today is what we call it as modified. We have the modified radical mastectomy. We have the modified radical mastectomy. Now, this modified radical mastectomy is also called as, or popularly referred to as, MRM. So this MRM stands for modified radical mastectomy. Now, what is this modified radical mastectomy? What do we do in this? Everything remains the same. The first thing, I am going to perform a simple mastectomy. That will happen. After you have done the simple mastectomy, unlike your radical, where you're removing pectoralis major and minor muscle, here I am only going to remove the pectoralis fascia. I'm only going to remove the pectoralis fascia. Usually, I will go ahead with level 1, level 2 and the level 3 group of lymph nodes will be removed, but there is here and there small exception. Now, in order to access, because you're not removing the muscle, you need to access these lymph nodes. So you have to play a little bit with your pectoralis minor muscle, right? So based upon that, you have 3 modifications of MRM. We have patties, we have scanlens, and then you have Auchincloss modified radical mastectomy. So 3 different MRMs that you have. One is your patties modified radical mastectomy. Another one is your scanlens modified radical mastectomy. And the last one that you have is your Auchincloss modified radical mastectomy. Now, when you try to understand the difference between these 3, you need to understand that how are we going to access the lymph nodes. That's the whole game that we're talking about. So here again, this is going to be the neck. This happens to be your shoulder line. This is the upper limb, suprasternal notch. This is the sternum. This happens to be the xiphisternum. This is the axillary groove. This happens to be the clavicle that is present, and this is the axilla that we have. Now, when you talk about the pectoralis minor muscle, we know it is going to insert from the coracoid process and insert from the 3rd, 4th, and 5th rib. So this is your pectoralis minor that we have. So this is the muscle that we have. So I'm just showing you the pectoralis minor muscle so that we understand it better. So based upon how do you play with your pectoralis minor to gain access? We have 3 varieties. We have the 3 varieties that you have. We have the patties, you have the scanlens, and you have the Auchincloss, right? Now, Dr. Harsh, DCIS, Dr. Acha, but in situ malignancies, if I have not taken it before, we'll deal it separately. Don't worry about it. Okay? So in Patty's modified radical mastectomy, I need to gain access to level 2 and level 3 group of lymph nodes. So in Patty's modified radical mastectomy, I am going to incise the pectoralis major muscle. So here we go ahead and we are going to incise the pectoralis minor muscle. So this is, we are going to excise the pectoralis minor muscle. This is your Patty's. If you incise the pectoralis minor muscle and retract it, this is what we call as scanlens. In Auchincloss method of modified radical mastectomy, I'm going to put a retractor to this muscle. I'm just going to simply put a retractor to this muscle and I'm going to retract it. So here we are simply going to put a retractor, and while applying the retractor, I'm going to retract the muscle. I'm going to retract the muscle laterally. So this is how I'm going to apply a retractor, and with the help of retractor, I'll just pull the muscle aside. So what you have done in Patty's modified radical mastectomy, you have taken the patient for pectoralis minor excision. Obviously, resuture it here. In scanlens, you have done the pectoralis minor incision. So I'm going to incise this muscle and then put a retractor on both ends. I'll put a retractor one end here and I'll put the retractor here. And then with the both ends, I'm going to retract the muscle and then try to go across here. So you have retracted the muscle. Okay. In Auchincloss, we are only going with pectoralis minor retraction, right? So 3 methods of modified radical mastectomy that you have. Number 1, it is going to be Patty's. Number 2, it is Scanlon's. Number 3, it is going to be Auchincloss method of modified radical mastectomy. Out of the 3 modified radical mastectomy, the most common type of MRM that we are following as of today is your Auchincloss method of modified radical mastectomy. Another important point that you need to understand, that in an Auchincloss modified radical mastectomy, level 3 group of lymph nodes are usually spared. Level 3 group of lymph nodes are usually spared in your Auchincloss method of modified radical mastectomy. Okay? So this is in the context of all the MRMs that you have. That's all the modified radical mastectomy, or the variants per se that are going to be present. Now, another very important thing is about what are the muscle flaps used for breast reconstruction. Okay, so once you've taken note, so I'm just going to quickly talk about flaps used for breast reconstruction. Flaps used for breast reconstruction. So I don't want you to memorize it like in a single, what we say that remember this, and this just you memorize it. We don't do that, right? We try to understand in where exactly it is present. For that, we will reconstruct our diagram, right? Now, imagine this is the patient who requires a breast reconstruction. Just for the sake of understanding. So this is the breast that we are going to remove, and then we are going to reconstruct it back, right? So here we need to be careful that what exactly are we talking about and in which context are we talking about. This diagram has to come a little bit more extensively. So I'm just trying to put it across here. So we need to know that where exactly you're going to take the flap from, what is the objective of the flap that you're going to follow, and all this will be taken into consideration, right? So let's say now this is the representation of the patient, and then you have to do a breast reconstruction here. So this is the nipple areolar complex. Okay. Now what we have done is we have now removed this part of the breast. So this is the tissue that is lost, right? So you have to reconstruct this. So I need various muscle flaps which are present. So what are the various muscle flaps that are going to present? Just for the sake of understanding, this is going to be the midline. This is the midline. Now the first muscle flap that you can take is going to be your latissimus dorsi muscle flap. So from here you can take this muscle flap and then reimpose here, and this is going to be your latissimus dorsi muscle flap. Another muscle flap that you can take is going to be from the abdomen, which is going to be here. When you take the muscle flap from the abdomen, this is usually a DIPE muscle flap. You have another one is called as tram also, but usually we'll be preferring DIPE. We'll talk about it. I'll just label it as we move, right? So the first one that you have, this is your latissimus dorsi myocutaneous muscle flap. Here your latissimus dorsi, myo is muscle, cutaneous is skin. So latissimus dorsi myocutaneous muscle flap. So I'm going to replace it here. When it comes down to here, you have two. Number one is what we call as DIPE. DIPE stands for deep inferior epigastric perforator flap. So you can take the DIPE and you can replace the breast from DIPE. Apart from DIPE, you can same area, you can have another one that is called as TRAM. TRAM stands for transverse rectus abdominis muscle flap. Now, as the name itself suggested, that in trap I'm going to take muscle, in tram I'm going to take muscle, in DIPE there is no muscle, right? So in DIPE it is only skin and subcutaneous tissue. So it is skin with subcutaneous fat. Whereas in tram you're going to take the skin, you're going to take the subcutaneous fat, along with that you'll also take the muscle. So when you take the muscle, no, from the abdominal wall, you're making the abdominal wall weak. You're causing the abdominal wall to get disintegrated. So in the same context, you're losing the integrity of the abdominal wall, resulting in incisional hernia, increasing the morbidity and all that. So currently, remember, the most common and the best that you can use for a breast reconstruction is going to be DIPE, that is a deep inferior epigastric perforator flap, that is going to be for reconstructive value. Now from the gluteal region, I have two flaps that we can extract. One is the superior gluteal flap, another one is the inferior gluteal flap. So one you can take is here, that is superior, another one you can take it from here, this is your inferior. There are two gluteal flaps that you can take. This is your superior gluteal muscle flap and this is your inferior gluteal muscle flap. So this is your superior gluteal artery perforator flap. Your superior gluteal artery perforator flap, and this is your inferior gluteal artery. This is your inferior gluteal artery perforator flap. This is your inferior gluteal artery perforator flap, right? Then there is another muscular flap that we can take. That is going to be from the thigh region. Same, you can take another one from the anterior side also. So this flap that you're going to take, this is what we call as profunda artery perforator flap. This is your profunda artery perforator flap. Perforator flap. Just opposite to that, you can take anterolateral thigh flap, which is here. This is your anterolateral thigh flap. This is your anterolateral thigh flap. This is your anterolateral thigh flap. And the last one that you can take is going to be just from the gluteal margin. You can say where the cleft is happening. From this area, you can take one last flap. And this is what we call it as the transverse upper gracilis myocutaneous muscle flap. This is going to be your transverse upper gracilis, that is a muscle, the gracilis muscle, or the gracilis myocutaneous flap, that is a muscle, myocutaneous flap, right? So these are the various muscular tissues or the flaps that you can use in order to do a breast reconstruction. Now for the breast reconstruction, remember all these are the muscle flaps, but the most common and the most important one is going to be DIPE, that is your deep inferior epigastric perforator flap. The advantage of DIPE is it does not take the muscle, only the skin and the subcutaneous fat, so not disrupting the contour or the integrity of the abdominal wall, so hence there is no particular morbidity, right? So these are the various breast surgeries that you should be knowing it, and we have discussed in detail about it. What are the structures to be removed, how do you proceed forward, and what are the components in total, right? So thank you so much for joining today. We'll resume back next week with the BLS series. Mota we have finished breast. There's like hardly one or two topics left. If time permits, I'll take a little bit of extra session in this week so that we close the breast and then we start a new system from the next week onwards. So all those guys who are live down there, what do you think we should start the next topic as? Any suggestions? Quick feedback. Any suggestions that you want me to take for the next week? Okay, Sauresh says urology. I wouldn't mind. Anybody else with a different suggestion? See, if you forget and you want to suggest it and you say, no, sir, we want this, you know where to reach out. Instagram and Telegram, we have a group. This is called as the Surgery Guy. And it's by my name. It is Dr. Sandeep Seeram Reddy. So reach out if you have any suggestions that you want to give. Okay. Okay, Mohammed Yunus says GIT. Okay. See, GIT, if we start, no, then we'll be sailing. So GIT is like, you know, it's the, we call it as the long last, I mean, it's an evergreen love for general surgeons. No, I know GIT is quite long. If we see, I would love to do GIT. Like we'll start, you know, with the esophagus. We'll go into the stomach. Then we'll talk about the small intestine. We can talk about hernia, bariatric surgeries. Then we go into colorectum, then into the anal canal, and then we continue into hepatobiliary, pancreas, and then on and on. So if we start GIT, no. See, until now we have finished 35, 36 episodes of BLS. I think today is episode number 35 or 36, if I'm not wrong. GIT alone will take 60 episodes. Okay? So without giving 60 episodes to GIT, you're not moving forward. So I think Mohammed Yunus, GIT is what I'm keen on as well. So let's explore GIT. Okay? So if you want to suggest more, you know where to write it down. I'll take a poll also. And all those guys who are up for it, let's discuss it. I'll put a poll on my Instagram as well as on Telegram group to see what topic or what system do you want in the next week. If you like urology, we'll go with urology. If you want GIT, we'll start with GIT, as you say so. Until then, thank you so much for joining. We'll resume back next week, same time, 9 to 10, BLS, Monday, Tuesday, Wednesday. Thank you for joining. Bye.